Most students prepare for OSCEs by memorizing long differential lists and then trying to recall them in that 5 minutes of prep before walking into the exam room. Ugh, that's stressful, and honestly, I think it's inefficient. In these chief complaint videos, I'll show you the framework I use to organize each chief complaint, safety first, then patterns, and then core diagnostic buckets. OSCEs aren't about listing diagnoses or blindly applying any physical exam you can think of. They're about demonstrating you can think clearly under pressure. So let's walk through the framework together. If you have a patient or OSCE chief complaint of dizzy, that's not even a diagnosis, and it's not even one system. Dizziness can mean vestibular, cardiac, neurologic, metabolic, or psych. So today, I'll show you the framework I use for a chief complaint like dizziness. As a student, I organized dizziness into safety first, then time pattern, and then 4 primary buckets. As I gain more experience, I'm sure this framework will expand, but this should hopefully get you through exams and early clinical reasoning. So let's walk through it. So our case today is a 58-year-old woman with dizziness. So the first thing I might ask is, what do you mean by dizzy, and could this kill them? I'd like to think of dizziness in 4 broad categories: disequilibrium, presyncope, vertigo, and non-specific. Before you enter the exam room with a patient or SP for OSCEs, I'd suggest taking a few minutes to list out a few top differential diagnoses by system or cause for the chief complaint. So for example, in our dizziness case today, that might look something like peripheral neurological causes, central neurological causes, maybe a couple cardiac causes, metabolic, medications, and even psych. So now we come to our first diagnostic fork, where we can ask more clarifying questions to help us understand what the patient means by dizzy. So you could ask the patient to describe, what do you mean by dizzy? If they say it's a feeling of spinning, but not lightheaded or faint, that could be more indicative of vertigo, which has a vestibular cause. If they say, I feel like I'm going to pass out, that might be more likely presyncope, which has a cardiovascular cause. If they say they feel off balance, that could be indicative of disequilibrium, which might be more neuro or MSK in origin. And lastly, if they say it's just general, non-specific, vague dizziness, then that maybe tells you there could be medication or anxiety or metabolic causes at play. So this question helps localize the system. If you skip it, then you can go down a completely wrong differential path. Okay, so now we can have more focused history questions. I like to use time as a pattern because it's one of our strongest differentiators. So if you asked, how long did the episodes last? And they say seconds, maybe that's more indicative of BPPV. Hours? Meniere's. Days? Probably more vestibular neuritis. You could ask if there's any hearing changes, ringing, or ear fullness. If there are, much more likely to be Meniere's than BPPV. You could ask them about any triggers of the dizziness. Often there could be specific positional triggers that the patient experiences that bring on the vertigo. And then, of course, it's always important to ask about red flag screening questions to help rule out those more serious central causes. So you could ask about any weakness, slurred speech, really severe headache, difficulty walking, numbness, especially on one side, the trifecta of dysphagia, diplopia, or dysarthria. If there's yes to any of these, central is more likely a cause than peripheral, and you should consider a stroke evaluation. So any focal neural deficits, any of these red flags, should be considered central until proven otherwise. Okay, so let's take a little closer look at our particular case. A 58-year-old woman presents to the clinic with recurrent episodes of dizziness over the past 3 weeks. She describes the sensation as the room suddenly spinning, particularly when she rolls over in bed, bends forward to tie her shoes, or looks up to reach into a cabinet. Each episode lasts less than a minute, but feels intense and unsettling. Between episodes, she feels completely normal. She also reports associated nausea during the spinning sensation, but denies vomiting. And she has not experienced hearing loss, tinnitus, oral fullness, headache, double vision, weakness, numbness, slurred speech, or difficulty walking. All good signs. She has not had a recent upper respiratory infection. She does recall lightly bumping her head on a cabinet door about a month ago, but did not lose consciousness and has had no lingering symptoms at the time. She states the episodes have made her anxious about moving too quickly And she now turns slowly in bed to avoid those triggering symptoms. She denies chest pain, palpitations, or lightheadedness when standing. Also all good signs. She reports not taking any new medications and has no prior history of similar episodes. Okay, so based on this case presentation, it's probably most likely that her dizziness is a vertigo. We've ruled out lightheaded, presyncope, and disequilibrium, or at least they're less likely. So here's a little algorithm I like to use to help me tease out what exams and what type of vertigo is going on. So let's walk through it together. We know that her dizziness is vertigo because the room is spinning. We know it's triggered with positional changes. So that puts us down the recurrent positional vertigo path and not the acute severe dizziness or recurrent dizziness episodes. Then we'd want to understand if her symptoms are consistent with BPPV. So we know that her symptoms less than a minute. She has no hearing changes, tinnitus, or ear fullness. So most likely, yes, it is consistent with BPPV. And then that would inform us that we should probably do the epi maneuvers to test if that helps resolve or reproduce her symptoms. Also, it's important to note that we ruled out any red flags, so it's less likely we need to consider a stroke evaluation for a central lesion at this time. Okay, let's revisit our initial DDX list that we made at the beginning. Based on our questions and the patient's history and intake, it's probably less likely that there's a central neurological cause at this point. Cardiac, metabolic, medications, or psych. So now we're just left with peripheral neurological causes. I think vestibular neuritis is less likely, and based on our history, we know that BPPV is floating to the top. So that's going to be my working diagnosis right now. And then as my backup top DDXs, I have vestibular migraine and Meniere's. Okay, so now we have enough information to make decisions about what informed physical exams we'd want to perform. So that's the nice thing, instead of having a bunch of spaghetti and random order of exams, we have a much more targeted approach. Don't forget to take vitals, especially in an OSCE exam. So here's a little table of what we have right now. We have a differential of BPPV, Meniere's, vestibular migraine, and central lesion is still there, just to be extra safe, especially in an OSCE setting. So we know the duration for each of these conditions, if there's any hearing changes, and if there's nystagmus, how that might present. So the key exam we could do for BPPV would be the Hallpike. For Meniere's, we could do a bedside hearing test. For vestibular migraine, we could get a history of her migraine, which we kind of already did. And then for a central lesion, to be extra safe, especially in an OSCE setting, you could do a neuro exam. So let's say we did all those exams. Let's check out our results. For Hallpike, we were able to recreate nystagmus, torsional and fatigable. For the hearing test, we found no asymmetry, so now Meniere's is less likely. For her migraine history, we recall that she denies having a history of migraines. This is the first headache like this. So probably less likely it's a vestibular migraine. And lastly, just to be extra safe, our neuro exam found that all of her tests were within normal limits. So that really speaks strongly for BPPV at this point. Okay, so based on everything we've done so far, let's present an assessment. If you're interested, I have a template for assessment writing in another video. But for now, let's focus on this patient. So we have a 58-year-old patient who presents to clinic with a 3-week history of recurrent, brief episodes of positional triggered vertigo, characterized by spinning sensation, lasting less than 1 minute, and occurring with rolling over in bed, bending forward, and looking upward. She reports associated nausea without vomiting and complete resolution between episodes. She denies hearing loss, tinnitus, oral fullness, headache, focal neurological deficits, or cardiovascular symptoms. In-office examination reveals normal vitals and a non-focal neurological exam. Hallpike maneuver on the right reproduced symptoms with transient fatigable, upbeat torsional nystagmus. No vertical or directional changing nystagmus was observed. Clinical presentation and exam findings are consistent with right posterior canal BPPV. In an OSCE setting, you might also need to present your treatment plan, and that could consist of patient education provided on recurrence and fall precautions, especially for someone in her age bracket, and arranging follow-up visit if symptoms persist or she experiences new neurologic or auditory symptoms. Okay, so that was dizziness in a nutshell. Remember, safety first, clarify what dizzy means, use duration to help narrow your differentials, and then confirm with focused physical exams. I hope that was helpful in your approach to dizziness. To help you study and prep for OSCEs, I put together a quick one-page reference sheet with the vertigo diagram we went through and a duration cheat table. It's totally free and the link is in the description below. Thanks for watching, and I'll see you in the next chief complaint.